In the public consciousness, the word plastic evokes artificiality, cheap manufacturing, and synthetic polymers. This perception makes the discipline synonymous with celebrity culture and aesthetic modification. However, the medical term shares no historical relationship with modern synthetic materials. It originates from the ancient Greek word plastikos, which translates to the art of molding or shaping living flesh. Humans have engaged in a relentless effort to modify and reconstruct the physical form for millennia. This drive spans across cultures and eras, reaching back far longer than the advent of social media filters. The foundations of this medical specialty grew from the urgent necessity to heal horrific bottle wounds, repair congenital differences, and restore the social identities of outcasts. The face is our primary biological interface. Because human survival depends on tribal cohesion, our brains evolved to extract complex data regarding identity, intention, and health from others within milliseconds. This diagram shows the specialized core face perception network. Visual data routes from the occipital face area directly into the fusiform face area to determine identity. Following this, the amygdala evaluates the face for typicality, influencing subconscious evaluations of trustworthiness and attractiveness. Faces deemed highly attractive and typical activate the brain's reward centers, flooding the network with positive reinforcement signals. Conversely, the brain registers uncertainty when encountering atypical or asymmetric features, causing the amygdala to fire rapidly. Aesthetic surgery allows individuals to optimize the social signals broadcasted to the neural networks of observers by surgically improving symmetry and harmonizing features. In 600 BCE India, nose amputation was a common legal punishment for crimes like theft or adultery, creating a population of visible outcasts. To restore them, physician Sushruta authored the Sushruta Samhita, realizing excised tissue requires a continuous blood supply to survive. Sushruta pioneered the attached flap method. He excised a section of living skin from the forehead, twisted it down over the nasal defect while keeping it attached to its original blood supply, and inserted wooden tubes to maintain the airway. This mastery of vascular dynamics remains the technical baseline for all modern reconstructive tissue transfer. The industrial warfare of World War I resulted in massive maxillofacial trauma. High-velocity projectiles and explosive artillery shells shattered soldiers' faces on an unprecedented scale. Surgeons discovered that simply stitching gaping facial wounds closed was inadequate. Pinary closure caused severe scar contractures, tight bands of tissue that twisted the remaining anatomy, rendering eyes unable to close and mouths unable to open. Surgeon Harold Gillies responded by inventing the tubed pedicle flap. By rolling a flap of skin into a closed tube, Gillies eliminated raw edges and preserved the blood supply. This allowed healthy tissue to be migrated in stages from a patient's chest up to their face. Modern plastic surgery formalized in these wards as an urgent military tool for returning mutilated soldiers to civilian society. During World War II, surgeon Archibald McIndoe treated fighter pilots who sustained devastating burns when their planes caught fire. McIndoe discarded standard treatments that caused crippling contractures, opting instead for continuous saline baths to rebuild faces and hands. McIndoe recognized that surgical reconstruction was only half of the medical requirement. He understood that long-term survival required psychological rehabilitation and social reintegration. He encouraged his patients, known as the Guinea Pig Club, to socialize in the local town while still undergoing treatment. By appearing in public with tissue flaps attached to their faces, the men forced the community to break down the stigma of disfigurement. The precise anatomical mastery used to rebuild a soldier's shattered jaw or reconstruct a breast after cancer is the same biological science used in modern aesthetic rhinoplasties. Through global conflict, medicine learned that restoring a human face is a prerequisite for restoring an individual's identity and dignity. Today, the power to mold flesh has collided with smartphone cameras, remote video calls, and AI-driven filters. Wide-angle lenses used in digital devices often distort facial features, artificially enlarging the central face. This unrelenting, inaccurate digital self-image has triggered a massive rise in clinical requests, a phenomenon termed Zoom dysmorphia. This environment creates significant risk for patients with body dysmorphic disorder. They hold the delusional belief that physical modification will resolve internal psychological distress. Surgeons now report an escalating crisis of the AI face, where patients demand the replication of algorithmic images. These flawless skin that completely defy the constraints of human anatomy and blood supply. Physical surgery cannot excise a psychological wound. If a patient's core perception is diseased, even a flawless operation is rendered useless. Current surgical reality often relies on harvesting tissue from one part of the body to patch another, or utilizing synthetic implants that are prone to eventual failure. Bioprinting technology utilizes the precise deposition of customized bioinks laden with a patient's living cells to construct functional human tissue architectures layer by layer. Advanced scaffolds provide the biochemical cues to coax the body to regenerate its own bone and cartilage. This technology aims to eliminate synthetic implants, allowing the body to truly heal itself using its own biological components. From ancient forehead flaps to high-fidelity bioprinting, the history of this discipline is the history of aligning the external physical avatar with the internal felt identity.